Welcome to the Deep Dive, the show where we transform complex info into clear, unforgettable insights just for you. Today we're taking a really fascinating journey. We're going deep into one of the most intricate systems in the body, the female reproductive system. It's, a microscopic world, but the coordination is just incredible. Our guide for this exploration is the fantastic Histology, a text and atlas, 8th edition. Think of it as our map to uncover the key stuff, the cells, the tissues, how structure relates to function, and we'll definitely touch on some interesting clinical correlations too. The goal, to get you really well informed, but without feeling like you're drowning in detail.
Exactly. And looking at it microscopically really reveals the elegance of it all. It's not just naming parts, right? It's about understanding this constant, intricate dance, cells changing, hormones fluctuating. It's all happening together, this whole orchestration for potential reproduction. Pretty amazing.
Okay, let's unpack the system then, piece by piece. So the internal sex organs, we're talking ovaries, uterine tubes, uterus, vagina, they're all located down in the pelvis. And then you have the external bits, the vulva mons, pubis, labia, clitoris, vestibule down in the perineum. And for this deep dive, we're also bringing in the mammary glands and the placenta.
Makes sense.
Yeah, because their function is so tightly linked to hormones and obviously to pregnancy.
Right. And what's key here is that these organs are constantly changing, from the first period, menarche, which is usually around, 12?
Yeah, about 12.4 on average, the text said.
Right, all the way to menopause, around 51. These organs are in this continuous cycle. It's driven by nerves, by hormones, always getting ready, potentially, for reproduction.
So let's kick things off with the ovaries. Paired, almond-shaped things, about 3 centimeters long. They've got two big jobs. First is gametogenesis, that's making the oocytes, the future eggs. And second, steroidogenesis. They're hormone factories, basically, making estrogens and progestogens.
Mm-hmm. And those hormones are crucial. Estrogens. Think growth and maturation. Sex organs. Secondary characteristics like breast development. And progestogens are more about preparation, getting the uterus ready for a potential pregnancy, priming the mammary glands for lactation later on.
Okay, so zooming in on the ovary structure. It's got two main zones, a central medulla that's loose connective tissue, big blood vessels, nerves, lymphatics, and then around that is the cortex. And that's where the action really is, right? That's where the ovarian follicles are, the little capsules holding the developing eggs.
Exactly. And a quick point about the very outer surface. It's covered by this single layer of cuboidal cells. Historically, people called it the germinal epithelium.
Ah, I remember that term.
Yeah, but it's a bit of a misnomer. We know now it's not where germ cells come from. But clinically, it's super important because something like 70% of ovarian cancers actually start right there on that surface epithelium.
Wow, okay. Good clarification. And it sits on top of a dense layer called the tunica albuginea.
That's the one. Dense connective tissue just underneath.
So the follicles, this is where the egg's journey begins. And they develop in stages. We basically group them into 3 types. Primordial follicles, then the growing ones, primary and secondary, or antral, and finally the mature or Graafian follicle.
Right, and get this, the primordial follicles, they're already there at birth. Each one has a primary oocyte that's basically paused. It's arrested in the first meiotic division.
Pause for how long, potentially?
Could be decades, from 12 years, maybe up to 50, just waiting, and it's surrounded by just a single layer of flat follicle cells, prequiescent.
Incredible. Then it transitions to a primary follicle. What happens there?
The oocyte gets bigger. And those flat follicle cells, they become cuboidal, start dividing, and form a stratified layer, multiple layers. We call that the membrana granulosa.
Made of granulosa cells. Okay.
And here's something cool. The oocyte itself starts secreting this layer called the zona pellucida. It's like an outer coat. It's got these specific glycoproteins, ZP proteins, that are absolutely essential later for sperm binding. And for triggering the acrosome reaction, which the sperm needs to penetrate, under the scope, it looks kind of glassy, refractile.
Right. And then the tissue around the follicle starts organizing too, into the ofocal layers.
Exactly. The stromal cells differentiate. You get the aloca interna, that's the inner layer, lots of blood vessels, secretory cells. It's got tons of electroreceptors and makes androgens, which are precursors for estrogen.
Precursors, okay.
And then outside that is the culca externa, more structural, with smooth muscle and collagen fibers. And this is where it gets really interesting. The teamwork for making estrogen.
Yeah.
The aloca interna cells, right? LH stimulates them. They make androgens.
Okay.
Those androgens diffuse over to the granulosa cells. Now, the granulosa cells, they respond to FSH, follicle-stimulating hormone, and they have this enzyme, P450 aromatase. They use that enzyme to convert the androgens into estrogens.
Ah, So neither cell type can make estrogen all by itself.
Precisely. It's a two-cell cooperation. The yucca makes the ingredients, granulosa does the final conversion. It's, efficient and allows for fine-tuned control.
And that connection to aromatase inhibitors in breast cancer treatment makes perfect sense now. You block that final conversion step.
Exactly. You lower the estrogen levels.
Okay, moving on. The secondary, or antral, follicle. What defines that stage?
Proliferation continues. The granulosa cells keep dividing, and little fluid-filled pockets start appearing between them. These pockets merge, coalesce, and form one big cavity called the antrum.
So antral means it has an antrum.
Yep. And by this stage, the oocyte has grown to its full size, about 125 micrometers, and it actually stops growing then. You might also see these little temporary things called Call-Exner bodies between the granulosa cells.
And how does the oocyte stay paused during all this growth?
Good question. There are molecular signals involved, things like cyclic GMP and C-type natriuretic peptide. They help maintain that meiotic arrest, keep it paused until the absolute right moment.
Then finally, the Graafian follicle. That's the mature one.
Right. The antrum gets really big. The whole follicle bulges out on the surface of the ovary. And the granulosa cells right around the oocyte form a little mound called the cumulus oophoris.
And the very inner layer of those stays with the egg.
Yes, that's the corona radiata. It gets released along with the oocyte during ovulation.
Okay, ovulation. The big release. How does that happen?
It's a hormone surge, primarily LH, that triggers a whole cascade. Increased fluid pressure inside the follicle, enzymes breaking down the follicle wall, even smooth muscle contractions in the theca externa. It all culminates in the follicle rupturing and releasing that secondary oocyte, usually about 14 days before the next period is due.
And that released oocyte is still technically paused, right?
Still paused.
Right.
Arrested in metaphase 2 of meiosis. It only finishes that division if and only if it gets fertilized by a sperm.
And if it doesn't get swept into the uterine tube, that's where ectopic pregnancy can happen.
Exactly. If it implants somewhere else, like the abdominal cavity, that's a serious situation.
So after ovulation, the follicle collapses. What happens to the leftover bits? The granulosa and the reducible cells.
They transform. They reorganize and become the corpus luteum, the yellow body. It becomes a temporary endocrine gland.
Right. And it has two cell types.
Two main types, yeah. Granulosa lutein cells, they're bigger, more central, come from the granulosa cells. They pump out progesterone, estrogens, and inhibin. And then the theca lutein cells, smaller, more peripheral from the theca interna. They make androgens and some progesterone. And both types, if you look closely, have tons of smooth ER and this mitochondria with tubular cristae, classic signs of steroid-producing cells.
And its fate depends on pregnancy, right?
Totally. No fertilization. It becomes the corpus luteum of menstruation. It lasts about 10, maybe 14 days, then degenerates into a scar of the corpus albicans, just a little white scar tissue.
But if fertilization does happen,
then it's rescued. The developing embryo starts making HCG, human chorionic gonadotropin. That hormone tells the corpus luteum, hey, stick around. So it becomes the corpus luteum of pregnancy, keeps making progesterone and estrogen for about 8 weeks, which is crucial for maintaining the early pregnancy, until the placenta can take over hormone production.
fascinating. And you mentioned most follicles don't even make it this far. Atresia.
Oh, yeah, the vast majority. Follicular atresia is programmed cell death, apoptosis. It happens constantly at any stage. It's the body's way of selecting usually just one dominant follicle to ovulate each cycle. Quality control, really.
Okay, shifting gears to the sperm's journey. Capacitation. What exactly is that?
Capacitation happens inside the female reproductive tract. It's basically the final maturation step for sperm, giving them the actual ability to fertilize. It involves changes like increased motility, membrane alterations, getting them ready for the big event.
And fertilization itself usually happens where?
Normally in the ampulla, the widest part of the uterine tube.
What are the steps?
Okay, so first, the capacitated sperm have to get through the corona radiata cells surrounding the oocyte.
Right.
Then they bind to those ZP receptors on the zona pellucida we talked about earlier. That binding triggers the acrosome reaction.
Which releases enzymes.
Exactly. Enzymes like hyaluronidase that help digest a path through the zona pellucida.
But only one sperm should get through.
Right.
How does the egg prevent polyspermy?
Multiple clever mechanisms. There's a fast block, a rapid electrical change, like flipping a switch on the egg membrane, that momentarily repels other sperm.
Okay, a quick zap.
kind of. Then comes the cortical reaction.
Hmm.
The egg releases enzymes from little granules just beneath its membrane into the space around it.
That leads to?
The zona reaction. Those enzymes modify the zona pellucida, degrading the sperm receptors and sort of hardening it, making it impenetrable to other sperm. It's like locking the door after the first one gets in. A permanent barrier.
Wow, a multi-step security system.
Pretty much. And what's really neat is how that successful sperm triggers the egg to finally finish its own division, meiosis II there. It releases a factor, likely PLC zeta, that wakes the egg up.
So the egg completes its process.
Yep. The sperm nucleus becomes the male pernucleus. The egg nucleus is the female pernucleus. They fuse, and boom, you have a diploid zygote, the very beginning of a new individual. And interestingly, the centrioles for that first cell division come only from the sperm.
Okay, let's follow that zygote. It travels down the uterine tubes, or fallopian tubes.
Right. These are paired tubes connecting the uterus to the area near the ovaries, about 10-12 centimeters long.
And they have different segments.
4 parts. The infundibulum is the funnel-shaped end near the ovary, with those finger-like fimbriae that sweep the egg in. Then the ampulla, the longest part where fertilization usually occurs. Then the isthmus, which is narrower and closer to the uterus. And finally, the intramural part, the bit that actually passes through the uterine wall.
What about the tube ball itself?
3 layers. Outer serosa, a muscularis layer intercircular, outer longitudinal smooth muscle for peristalsis, and the inner mucosa, which has prominent folds, especially in the ampulla. No submucosa, though.
And the lining of the tube?
Simple columnar epithelium, 2 key cell types, ciliated cells with little hairs beating towards the uterus to move the oocyte along,
Okay.
and non-ciliated peg cells. These are secretory. They provide nutrients for the traveling ovum and sperm. And their activity changes with the hormone cycle. Estrogen stimulates cilia growth. Progesterone stimulates the peg cells.
Nicely synchronized.
Yeah.
Okay, onto the uterus. The womb, pear-shaped, hollow.
Yep, the site of fetal development.
Yeah.
You've got the main body, the rounded top part or fundus, and then the lower, narrower cervix that opens into the vagina.
And the wall is thick, right? 3 layers again.
3 layers. The endometrium, that's the inner lining, the mucosa. The myometrium, the really thick muscular layer responsible for contractions. And the permetrium, the outer serous layer. And that myometrium has a layer packed with blood vessels, the stratum vasculaire.
The endometrium is the one that undergoes the menstrual cycle changes, preparing for implantation.
Exactly. It's incredibly dynamic. It has 2 layers itself during reproductive years. The stratum functional, the thick upper layer that gets shed during menstruation.
Right.
And the stratum basale, the deeper layer that stays behind and regenerates the functionalis each cycle. And those spiral arteries are key here. They supply the functionalis and undergo cycles of growth and constriction.
So the menstrual cycle phases in the endometrium. First, proliferative.
Proliferative phase, yeah. Driven by estrogen from the developing follicles. Everything's growing: glands, stroma, blood vessels. Glands are pretty straight. Endometrium thickens up maybe 1 to 3 millimeters. Rebuilding phase.
Then the secretory phase.
Now, progesterone from the corpus luteum takes over. The endometrium gets even thicker, maybe 5 or 6 millimeters, becomes more edematous, watery. The glands become really coiled like corkscrews and fill up with glycogen-rich secretions, preparing the bed for the embryo. Spiral arteries lengthen, become more coiled.
And if no pregnancy, the menstrual phase.
Hormone levels drop. The corpus luteum degenerates. That withdrawal of progesterone causes the spiral arteries to constrict intermittently. This cuts off blood flow, ischemia, to the functionalis. The tissue starts to break down, blood vessels rupture, and the whole stratum functional is shed. That's the menstrual flow. Then the cycle starts again from the basal layer.
But if fertilization did happen, the blastocyst implants.
Right. It embeds in that receptive secretory endometrium. And the developing embryo, specifically the chorion, starts pumping out HCG.
The signal to maintain the corpus luteum.
Exactly. So progesterone stays high, the endometrium is maintained, no menstruation.
And the endometrium changes further.
Decidualization.
Yes. The stromal cells transform under progesterone's influence. They enlarge, become rounded decidual cells. It's a crucial reaction for implantation and placenta formation. We name parts of it based on location. Decidua basalis under the embryo, capsularis covering it. Parietalis is the rest of the uterine lining.
Okay, what about the cervix? Its lining is different. Very different. The cervical mucosa doesn't get shed during menstruation. It has large branched glands that produce mucus.
And that mucus changes consistency.
Dramatically. Mid-cycle, when estrogen is high around ovulation, the mucus becomes thin, watery, alkaline, perfect for sperm to swim through. Other times, under progesterone influence, it becomes thick, viscous, acidic, forming a mucus plug that kind of blocks the cervical canal, a natural barrier.
And that specific spot on the cervix, the transformation zone, why is that so important clinically?
The squama-columnar junction. It's where the vaginal type epithelium, stratified squamous, meets the cervical glandular epithelium, simple columnar. That transition area is where cells are actively changing, undergoing metaplasia, and it's particularly vulnerable to infection with high-risk strains of HPV, human papillomavirus,
Which can lead to cancer.
which is why it's the primary site for cervical dysplasia and cancer, and why the Pap test, looking at cells scraped from that zone, and now HPV testing, are so vital for early detection.
Okay, let's talk placenta. Temporary organ, but absolutely essential, formed by both baby and mother tissues.
Right. Fetal part is the chorion, maternal part is the decidua basalis. It's the interface. Allows exchange without mixing blood.
How does it develop those exchange structures?
It starts with spaces called lacunae, forming in the early placental tissue. Then finger-like projections, villi, grow into these spaces. They start simple, primary, get a connective tissue core, secondary, and then develop fetal capillaries inside, tertiary. These tertiary villi are the functional units.
So the placental barrier separates maternal and fetal blood. What makes up that barrier?
It's several layers, but remarkably thin overall, especially later in pregnancy. You've got the syncytiotrophoblast, outer layer of the villus, sometimes cytotrophoblast beneath it. Their shared basal lamina, the villus connective tissue, the fetal capillaries basal lamina, and finally the capillary endothelium itself.
Thin for efficient exchange.
Exactly. Oxygen, nutrients, antibodies go from mom to fetus. Waste products go from fetus to mom.
And the blood flow pattern.
Fetal blood comes in through 2 umbilical arteries, goes through the capillary networks in the villi, and returns oxygenated and nutrient-rich through the single umbilical vein. Maternal blood squirts into the spaces between the villi from spiral arteries, washes over the villi surfaces, and then drains out through endometrial veins. Again, no direct mixing.
And hormones. The placenta makes a ton of hormones.
Oh, yeah, it's a major endocrine organ. Progesterone, definitely. Estrogen, too, but it needs androgen precursors from the fetal adrenal gland. That's the fetoplacental unit working together.
What else?
Protein hormones, too.
Yeah.
HCG, which we mentioned to maintain the corpus luteum. HCS, human chorionic somatomammotropin, which affects maternal metabolism, helps ensure glucose for the fetus. Relaxin, leptin, growth factors, a whole cocktail.
Any clinical issues with the placenta itself?
Sometimes it'll touch us too deeply into the uterine wall, placenta accreta, increta, or percreta, depending on the depth of invasion. That can cause severe bleeding during delivery.
Okay, moving down to the vagina. Fibromuscular tube.
Connects the cervix to the outside. Lined with stratified squamous, nonkeratinized epithelium, tough, protective. Has folds called rugae that allow it to stretch.
And lubrication doesn't come from glands in the vagina itself.
Correct. No glands in the vaginal wall. Lubrication is mainly from cervical mucus plus secretions from the vestibular glands near the opening. But the vaginal lining cells do play a key role in its environment. Under estrogen, they produce glycogen.
Glycogen.
Then, beneficial bacteria, Lactobacillus acidophilus, break down that glycogen into lactic acid. This keeps the vaginal pH low, around 4.
Which is protective.
Very protective. That acidic environment inhibits the growth of many potential pathogens, a clever natural defense.
And the external genitalia, the vulva.
Includes the mons, pubis, labia majora and minora, the clitoris, which is erectile tissue, like the penis, and the vestibule, the space enclosed by the labia minora where the urethra and vagina open. Also contains vestibular glands for lubrication. Lots of sensory nerve endings there, too.
Right. Finally, let's talk mammary glands, modified sweat glands, right?
Modified apocrine sweat glands, yeah, tubulo-alveolar type. And incredibly dynamic, their structure changes dramatically with age, the menstrual cycle, and especially pregnancy and lactation.
How do they develop?
Pretty rudimentary until puberty. Then in females, estrogen drives duct growth and fat deposition. Progesterone helps develop the glandular elements, the potential milk-producing parts.
Structurally, they're organized into lobes.
About 15-20 lobes, separated by connective tissue containing those suspensory ligaments, Cooper's ligaments that provide support. Each lobe is made of smaller units, lobules. The functional unit is the TDLU, terminal duct lobular unit. In an inactive gland, this has terminal ductules. In a lactating gland, these develop into secretory alveoli, the actual milk-producing sacs.
And the duct system.
Milk goes from alveoli into intralobular ducts, then interlobular ducts, then into larger lactiferous ducts. Each lobe has one main lactiferous duct that opens at the nipple. Just behind the nipple, there's a swelling called the lactiferous sinus, a little reservoir. And surrounding the alveoli and ducts are myoepithelial cells. They contract like smooth muscle to help eject milk.
Do they change much with the regular menstrual cycle?
Subtle changes. In the luteal phase, under progesterone, there can be a little bit of proliferation in the ductules, some fluid accumulation in the connective tissue, maybe slight tenderness. Then it regresses, minor fluctuations.
But pregnancy is the big change.
Huge change, massive proliferation of the glandular tissue. The alveoli develop fully, the breast enlarges significantly. It's driven by that whole hormonal symphony: estrogen, progesterone, prolactin from the pituitary, HCS from the placenta, even glucocorticoids. Everything gets ready for lactation.
How is milk actually made and secreted? Two ways.
Two main mechanisms for different components. The protein parts of milk casein, lactalbumin, are made in the rough ER, packaged by the Golgi, and released by standard exocytosis. That's merocrine secretion.
Okay.
The fatty component, the milk lipids, are different. They form droplets in the cytoplasm, coalesce into larger drops, move to the apical surface, and then bud off, taking a little envelope of cell membrane and cytoplasm with them. That's apocrine secretion.
Interesting. And the first milk is different, colostrum.
Yes, colostrum. It's produced for the first few days after birth. It's yellowish, lower in fat, higher in protein and vitamin A. But crucially, it's packed with antibodies, especially secretory IgA.
Providing immunity?
Passive immunity for the newborn. It's incredibly important protection. Then true milk, which is richer in lipids and lactose, comes in a few days later.
And lactation is controlled by hormones triggered by suckling.
It's a beautiful neurohormonal reflex. Suckling stimulates sensory nerves in the nipple. Signals go to the hypothalamus. This inhibits dopamine release, which normally suppresses prolactin, so prolactin levels rise. Prolactin drives milk synthesis.
And milk ejection.
Same suckling stimulus also triggers the release of oxytocin from the posterior pituitary. Oxytocin travels to the breast and causes those myoepithelial cells to contract, squeezes the milk out of the alveoli into the ducts, the milk ejection or letdown reflex.
Got it. And hypolactin can suppress periods.
Often does, yeah. Lactational amenorrhea. Prolactin can inhibit GnRH release from the hypothalamus, suppressing the whole ovarian cycle. And then after menopause, when ovarian hormones decline, the mammary glands atrophy, involute. Less glandular tissue, more fat and connective tissue.
Wow. What an incredible, intricate journey we've taken. From the ovary cycles to fertilization, pregnancy, the placenta, and finally lactation. The level of cellular detail and hormonal control is just, well, staggering.
It really is. Seeing it at the histological level just drives home how precisely everything is coordinated.
As you think about all this, the follicles developing, the endometrium cycling, the placenta forming, milk being made, consider how these microscopic events underpin life itself. Does looking at this level of detail change how you think about the body's resilience, its adaptability? Maybe give you a new appreciation for the complexity humming away inside us all the time, something to ponder. Thank you so much for joining us on this deep dive today and for being part of the Deep Dive family. Keep exploring the amazing world within.